for anatomical outcomes after treatment with Nd:YAG laser versus intraretinal anti-VEGF injection.
Good afternoon, everyone. Today my talk will be comparison between anatomical outcomes after laser versus injection. Understanding retinopathy of prematurity, what is ROP? ROP is a vasoproliferative disorder of retinal vessels affecting premature newborns. It occurs when abnormal vessels develop in retina. The primary criteria in India is gestational age of 34 weeks or birth weight less than 2,000 grams. A secondary criteria is 34 to 36 weeks with risk factors, and screening schedule starts at 31st week post conceptional age or 4 weeks after birth, whichever is later. These are the zones. For the localization of vascularization, we divide retina into zones: zone 1, zone 2, and zone 3. And also, depending upon at the junction of vascularized and avascularized area, we divided the ROP into stages. Stage 1 is demarcation line, stage 2 demarcation ridge, stage 3 is extraretinal neovascular proliferation, stage 4 is partial RD, stage 5 is total RD. For indication of laser is type 1 ROP, threshold ROP, and patients whose follow-up is not reliable. And anti-VEGF is contraindicated. And indication for intravitreal injection is type 1 ROP in zone 1 and AROP. AROP doesn't follow the rules of stages of ROP and it shows rapid progression. And when laser is difficult and dangerous, it's also contra or institutional constraints are seen. There is critical need for timely intervention. Mostly, only 5 to 10% babies require treatment. Only by early detection, treatment window. At specific treatment window, it's very crucial to treat such childs to prevent long-term impact. Current approaches are anti-VEGF injections, which we use bevacizumab, ranibizumab, and aflibercept. Aflibercept has been accepted as FDA approved from February 2023. Laser, we use Nd:YAG double frequency green laser to ablate the avascular area. Study design, we have selected patients who need basically type 1 ROP, which require treatment, and we allocate the patients to the group. We have taken total 40 patients divided into 2 treatment groups, group A, group B, and anatomical outcomes are compared according to that. And these shows the demography. 22 anti-VEGF patient was given and 18 patients were given laser. We have divided the anatomical outcomes into 2 parts, favorable and unfavorable. Favorable includes ROP regression, and unfavorable include retinal hemorrhages, vitreal hemorrhages, retinal detachment, and persistent avascular area. Anti-VEGF is given in group A, which under standardized protocol, and a laser was given with Nd:YAG double frequency green laser, targeting the avascular area. And anatomical analysis was done when we have seen from 18 patients out of 17 patients out of 18 show regression, and 21 patients out of 22 patients shows regression, showing the favorable outcomes. And immediate treatment response was seen that the eyes treated with anti-VEGF injection demonstrated faster resolution with the plus disease and neovascularization. 95.45% of patients shows regression, and laser treated patient shows gradual but consistent regression of ROP. And regression occurred in intravitreal injection patient compared to that of the patient shows no statistical difference in patients in our study. Supporting evidence from literature, these are the studies we have seen showing the similar results. And study limitation is that the current study limitation is relatively small size of the data, single center study, and follow-up durations are constrained. Lack of the long-term visual assessment is absent. Future research priorities are large-scale multi-center randomized trial, long-term visual and refractive outcomes, cost-effectiveness analysis, and optimal dosing and retreatment protocols. These are few of the cases. Zone 2, stage 2 with pre-plus disease, 7-hour clock of extent of the disease, and after laser, there is somehow resolution of the pre-plus disease and better regression is also seen. This is stage 2, zone 2, stage 2 with plus disease with a 8-hour clock of extent. This is before and after injection. And also in specifically in laser patient is in patients with zone 1 disease, posterior zone 2 stage 2 with the plus disease 8-hour clock of extent after injections showed quite a good regression. Conclusions, we both intravitreal and Nd:YAG photocoagulation are equally effective for ROP, each with distinct advantages and limitations. Anti-VEGF injection provide rapid initial regression with fewer procedural complications but higher recurrence risk requiring closer monitoring. Laser photocoagulation, they offer more sustained anatomical outcomes with lower recurrence rate at the cost of peripheral retinal ablations, and treatment selection should be individualized considering the disease severity, anatomical location, and follow-up capabilities. Thank you.
Good afternoon, everyone. Outcomes of pan-retinal photocoagulation in patients of diabetic retinopathy. The prevalence of diabetes in urban India is 15% and is 19%, and rural is 15%, which is relatively higher to that of the world. The risk factors are modifiable and non-modifiable. The modifiable being glycemic control, hypertension, dyslipidemia, and non-modifiable being the duration of diabetes. The DCT study showed that 75% of reduced risk of development of diabetes with tighter HbA1c control. The prevalence of diabetes. Next news. In 2016, a study done by Mukhtar et al., where 67 eyes of patients of PDR were included and CMT and BCVA were documented. The mean treatment BCVA pre-treatment was 0.67 and post-treatment was 0.57, and CMT measured on OCT pre-treatment was 391 micrometers and after treatment was 316, which showed. So the research question arose that what would be the outcomes of diabetic retinopathy, and that is what we did to help in patient counseling. So the objective of the study was to study these functional effects. Ours was a descriptive study done on adults above 30 years of age over 1 year after ethics approval from GMC Amritsar, done in the Department of Ophthalmology at RIO Amritsar. So we included all patients above 30 years with DR of any gender undergoing PRP for the first time and willing to enroll in the study. Exclusion was not willing to participate and with advanced lenticular opacities of prior treatments and with cognitive impairment. So the detailed clinical examination was done. Visual acuity by Snellen's chart, refraction, and BCVA was noted. Slit lamp microscopy of the anterior segment was done. Posterior segment was done with indirect ophthalmoscopy with 20D and slit lamp with 90D. IOP was done by GAT, and OCT was done by NIDEC RS330 for macular map scan. So pan-retinal photocoagulation was done in patients as per the protocols of the hospital with 532 nanometers Nd:YAG slit lamp delivery system and quadricepheric lens. Regular follow-ups at 1 month, interval done for 3 months, and then 6 months post-laser. During each studies, the patient was evaluated under the standard ophthalmic exam of visual acuity, IOP, and OCT. So we did stats using MS Excel, and out of 32 patients, 62.5% of patients were males and 37.5% were females. Maximum patients were in the age group above 60 years, and 87.5% of patients had PDR and 12.5% had very severe NPDR. We measured the outcomes in terms of visual acuity and CMT. The visual acuity on logMAR before intervention was approximately on an average 660, and after intervention at the end of 6 months was 6.9, and there was a 72% improvement in patients. The central macular thickness post-intervention improved by 29%. The pre-treatment was around 405 microns, and post-treatment went to 287. The clinical implication of our study was that there are desirable outcomes in visual acuity and central macular thickness, which helped in better understanding and patient counseling for tighter diabetic control and better HbA1c control. So, And the demerits were that long-term side effects of PRP could not be evaluated due to loss of follow-up and shorter duration of the study. Thank you.
Hello. Good afternoon, everyone. Today's my topic is snake bite surprise. Uh, Basically, snake bite is the commonest life-threatening medical emergency in the Indian populations, and it is known for the systemic manifestations. Viperine venom that contains hemotoxins that known to cause vascular toxicity. Although venom may contain neurotoxins too, the clinical manifestation of the neurotoxicity following the viperine bite is rare. However, the ocular involvement is extremely rare and mostly underreported. Here we are presenting a case of viperine snake bite with the features of vascular toxicity and neurotoxicity in the one eye. Normally, viperine snake bite causes the bilateral involvement, but in our case, it is causes unilateral involvement of the vascular toxicity and neurotoxicity. So we followed this case for the 3 months for the vitreous hemorrhage, and for that we have given the oral steroid, but it is not resolved. It was not resolved. The case was 35 years old, previously healthy male patients, had sustained viper bite to right foot. For that, he admitted to ICU for the management of snake bite and for the close monitoring of any systemic manifestations. He developed cellulitis in affected limb, then stabilized with antivenom, antibiotics, and the supportive care. Then he also complained of decreased vision with eyeball deviations in the left eye. So we followed that case for 3 months. This is the viper snake bite. That the photo was took by that patients also. This is viper snake bite, and this causes the lower leg cellulitis in the right leg. So Maxwell application is applied, and this is the photo showing the viper snake bite marks after 3 months. After 3 months, the visual acuity in the left eye is perception of light and projection of rays in all quadrants is positive. Then visual alignment is 30 prism diopter exotropia in the left eye. No signs of any ptosis, diplopia or active motility restrictions. Anterior segment within the normal limit in the both eyes. The fundus in the right eye is normal, that is this macula appears normal, vasculature is normal, but in the left eye at the same time vitreous hemorrhage is present. This thick vitreous hemorrhage is present. B scan of the left eye showing the thick vitreous hemorrhage with query of the tractional retinal attachment over the posterior pole, and this is the picture showing the exotropy of 30 prism diopter with the help of Hirschberg corneal reflex test. Other investigations we have done, but that was all within the normal limit, even the IGRA test, ECG within normal limit, KFT within the normal limit. So we did a surgery for the vitreous hemorrhage, that is vitrectomy. Initially we made a 3 ports of 25 gauge vitrectomy. Then after we complete the vitrectomy, there is thick vitreous hemorrhage was present. After that, as this is a young patient, PVD is thick and strong attachment, we remove that. After that, we see a serous retinal detachment in temporal periphery, that we made a iatrogenic tear for that, and after that we applied the endo laser for to the tear, and after this after fluid exchange, oil injections were done. So in post-operative care, topical steroid antibiotic was given, and close follow-up of IOP measurement and PVR changes and retinal status was done. This is after first post-operative day. The pictures, that is retina is attached, disc and macula appears normal, the laser marks to the tears present. The scar after first month, third month, the retina is attached. After that, we remove the silicone oil after the 3 months, and after the 3 months, the cataract was developed to the patient. Then cataract surgery also done. The vision remains stable at 6/18, and there is no recurrent detachment. But the exotropy of left eye was reduced, but it is not totally gone. There is no signs of diplopia, activity, motility restriction after that. So this is the after 2 months of silicone oil removal. We can see this retina is attached. The picture is not clear due to the cataract is present in the patient's eye. This is after cataract removal. The right eye fundus is normal, left eye fundus is normal. There is an artifact of the machines, but exotropy of tail prism diopter present in the left eye. So, possible mechanism in this case, because this snake bite causes the bilateral involvement, but due to the anatomical difference in the vasculature between the two eyes and asymmetrical toxic distribution before it reaching to the systemic circulations, that leads to the unilateral presentation. It direct causes the retinal vascular damage, leads to the vascular hemorrhage and secondary retinal detachment. Exotropia may be due to the extraocular muscle involvement or cranial nerve involvement, or with very the small part of involvement of sensory component. So ocular complications from the snake bites are rare but visual threatening, and surgical intervention like vitrectomy is helpful for this. So take-home message is viper snake bite can cause unilateral vitreous hemorrhage with serious detachment with exotropia. Early diagnosis with timely management leads to the favorable visual outcome. The symptoms affecting only one eye warrants the same level of diagnostic scrutiny as this bilateral presentation, and long-term of follow-up of this required for any PVR changes, recurrent detachment, or any persistent strabismus. Thank you.
Good afternoon. The topic for my two-way presentation is retinitis pigmentosa. Retinitis pigmentosa is progressive degeneration that typically starts with the involvement of rod's photoreceptor followed by cone's photoreceptor. Thus, it is classified as rod cone dystrophy. Although retinitis pigmentosa usually affects the eyes, it can also occur as a part of syndrome and result of systemic condition in 20 to 30% of cases. The most common syndromic association is Usher syndrome, in which RP is accompanied by hearing difficulties and possible vestibular ataxia. Global prevalence of RP is 1:5,000. Approximately 50 to 60% of RP are inherited in autosomal recessive pattern, 30 to 40% in autosomal dominant pattern, and 5 to 15% in autosomal X-linked pattern. History. A 60-year-old female presented to IOPD with complaint of gradual progressive painless diminution of night vision in both eyes for 2 years and peripheral visual disturbance with no aggravating or relieving factor, and it is not associated with pain, watering, or any other discomfort. The past history was within normal limit. There was no family history of similar illness in any of the family members. There was no significant history of drug or any other prolonged topical eye drops. General examination, all the parameters were in the normal limit. In systemic examination, everything was in the normal limit. Ocular examination, both I had cataract, thus the vision was finger counting 1 and finger counting 1 in both eyes. The best corrected visual acuity was 6/36 for the both eyes. Rest anterior segment was within the normal limit. Due to the cataract, the media was hazy in the both eyes. The color of disc was waxy pallor. The disc shape was normal. CDR was 0.5 and 0.6 in respective eyes. Vessels was attenuated and bony spicules in all the quadrants in the periphery was seen. Foveal reflex was dull. Confrontation test was done, which shows restriction of visual acuity in the peripheral quadrant. Color vision was intact in both eyes. Contrast sensitivity was reduced. Perimetry couldn't be done as the patient had poor fixation, making the reliable field mapping very difficult. The diagnosis was clinically evident and classical fundus features and OCT findings, hence the ERG was not done. This is the OCT of both eyes. This OCT shows there is macular sparing with no macular edema. Based on clinical finding and investigation, diagnosis of both eye retinitis pigmentosa with macular sparing was made. Management, proper counseling of patient was done. In medical management, patient was advised to take 15,000 international unit of vitamin A with regular follow-up to prevent vitamin A hypertoxicity. For surgical management, patient was advised for cataract extraction surgery, and the patient was further advised for visual aids, rehabilitation training, and genetic testing. Thank you.
Good afternoon, everyone. I'm Dr. Disha Shri, presenting a case report titled Delayed Scleral Buccal Exposure with Infection Post-Giant Retinal Tear Repair. Scleral buckling remains a time-tested adjunct in retinal detachment surgeries. However, buccal complications like late buccal infection and exposure can threaten both vision and globe integrity. Reporting such cases adds to the limited literature and reinforces the importance of long-term vigilance. The objective of our work is to present a case of delayed scleral buccal exposure with infection following retinal detachment surgery for a giant retinal tear, emphasizing the importance of long-term vigilance, patient compliance, and early intervention in buccal-related complications. Our patient was a 60-year-old male with a history of complicated cataract surgery who was later diagnosed with rhegmatogenous retinal detachment with a 270-degree giant retinal tear. He was managed with pars plana vitrectomy, silicone oil tamponade, and a segmental scleral buccal in 2022. Unfortunately, the patient was lost to follow-up. The patient presented nearly 34 months later with pain, redness, and purulent discharge. An exposed infected buccal was seen temporally on slit lamp examination. The visual acuity in the affected eye was 1/60. The retina was attached with emulsified oil in situ. These are the slit lamp images when the patient presented to us, demonstrating conjunctival dehiscence and exposure of the anteriorly displaced temporal scleral buccal. We proceeded with scleral buccal removal. Intraoperatively, the buccal showed surface degradation and biofilm-like debris consistent with chronic infection. The buccal was excised in pieces and local irrigation was performed. These are the removed infected segments of segmental scleral buccal. Postoperatively, the patient was maintained on topical antibiotics and steroids, following which inflammation resolved. The retina remained attached with emulsified oil. The best corrected visual acuity stabilized at 1/60. To conclude, I would like to say that retinal detachment surgery does not end with anatomical success. Buccal-related complications may present even years after surgery. Therefore, patient compliance and vigilant long-term monitoring become crucial in early detection and timely intervention in buccal-related complications to prevent vision and growth-threatening sequelae. Our case underscores two key aspects. First, chronicity, that complications can manifest even years after the primary surgery. And secondly, management, that conservative measures are rarely effective in established buccal infections. Only prompt removal halts progression, preserves globe integrity, and maintains retinal attachment. I've listed a few key references around scleral buccal infection and their management. With that, I would like to conclude by saying that our surgeries succeed not only in the operating rooms, but also in the years that follow. Even successful retinal detachment repair demands long-term vigilant surveillance to prevent late vision-threatening buccal-related complications. Our message to patients remain clear. Compliance today means vision tomorrow. Thank you.
Good afternoon all. My topic for presentation is an unilateral best vitelliform vacuolar dystrophy with CNVM well managed with anti-VEGF. I have no financial disclosure and conflict of interest. Best disease is usually an autosomal dominant macular dystrophy. There is a mutation seen in BEST1 gene. It is usually bilateral and sometimes can be unilateral, and in some cases it can lead to CNVM formation. Epidemiology. Onset is generally seen in childhood to early adulthood. There is an equal distribution among male and female. Unilateral cases are extremely rare, and CNVM complicates around 20 to 30% of cases. Materials and methods. Detailed case documentation was done, recording of best correctal visual acuity, anterior segment examination with slit lamp, intraocular pressure measurement with applanation tonometry, fundus evaluation with indirect ophthalmoscopy and fundus photography, spectral domain optical coherence tomography, OCT angiogram for CNVM confirmation. An intraocular and electrooculogram was done to detect subclinical dystrophy. My patient was a 33 years female who presented with blurring and distortion of vision in left eye with gradual progression over 3 months. No family history of similar condition was seen. Best corrected visual acuity in right eye was 6/6 and in left eye was 6/18. Anterior segment of both eyes were within normal limits. IOP used an applanation tonometry
was done, and right eye showed 16 millimeter of mercury, left eye 14 millimeter of mercury. Fundus examination showed egg yolk-like vitelliform lesion in left eye with signs of CNVM like hemorrhage, exudation, and right eye showed an absolutely normal fundus. EOG showed Arden ratio of 1.3 in left eye and 1.4 in right eye. OCT of left eye showed hyperreflective vitelliform material over macula, subretinal fluid, CNVM membranes, and retinal pigment epithelium changes. OCT of right eye was normal. Management and outcomes. The patient was treated with intravitreal anti-VEGF ranibizumab injection. The first dose was given on 22nd of February 25. Vision subsequently improved from 6/18 to 6/12 after 1 month. OCT angiogram, which was done after 2 months interval, showed some active CNVM. Therefore, the patient was given a second intravitreal anti-VEGF, which was given on 25th of April. Post anti-VEGF status, patient vision remained at 6/12 in 2 weeks. OCT, which was subsequently done 1 month after that, showed some amount of subfoveal scar over macula with no subretinal fluid suggestive of scarred CNVM. Patient was followed up at 3 months and 6 months. Vision remained stable at 6/12 in follow-up visits. Discussion. Rare unilateral presentation, this highlights variability. It helps us in identifying the stage of presentation, like whether it is pre-vitelliform, pseudo-hypopion, vitelli-eruptive, atrophic, or CNVM. There is an importance of differentiating it from AMD because it also manifests with similar presentations. Role of multimodal imaging in diagnosis and timely anti-VEGF regimen improves outcomes. Unilateral best disease CNVM is rare, but it is significant. Early detection with OCT and FFA is crucial. Anti-VEGF effective for CNVM management, so a good regimen is very much crucial. Advise vigilant monitoring of fellow eye for any visual decline. It can be done by an EOG to see any subclinical dystrophy if at all present. Lifelong monitoring is essential for prognosis. These are my references. Thank you so much.
Good afternoon, everyone. I'll be presenting a case of optic disc pit maculopathy that was initially diagnosed as central serous chorioretinopathy. So serous macular detachments presents diagnostic challenge in clinical practice, while central serous chorioretinopathy remains the most common etiology. Atypical presentation requires systemic evaluation for alternative diagnosis. So optic disc pit is a rare congenital cavitary anomaly of the optic nerve head. Prevalence is among 2 in 10,000, usually unilateral, but 15% may be bilateral, appear as a grayish depression, most commonly seen in the inforotemporal part of the disc. 25 to 75% cases of this optic disc pit develop maculopathy with serous macular detachment and retinochisis. Pathogenesis remains unclear. Fluid may arise from vitreous, subarachnoid space, or disc vasculature. So 44-year-old male patient presented with painless gradual blurring of vision in the left eye persisting for 2 months. There was no history of any systemic illness, prior ocular trauma, ocular disease, or no medication or steroid use was there. Visual acuity in the left eye was 20/60 with no improvement with refraction. Pupillary response was normal and reactive. Anterior segment examination was unremarkable. And on fundoscopy, we can see an extensive serous macular detachment with the subretinal deposits. So initial fundus examination revealed classical features suggesting central serous chorioretinopathy, prompting further imaging studies. So OCT macula was advised, and we can see serous retinal detachment with disruption of photoreceptor layer integrity with increased central macular thickness. Then fundus fluorescent angiography was advised, and we found that there was absence of focal ink blot leak at the fovea, which was seen in typical CSCR pattern. There was no smokestack leakage present in the macular region, but a faint diffuse hyperfluorescence was noted in the peripapillary region. As there was no active focal leakage points identified at the macula, so these atypical angiographic findings prompted re-examination of the optic disc, leading to a detection of a subtle inferotemporal pit. So we advise OCT optic nerve head, and we can see the optic disc pit over here. So the findings, focal depression at the inferotemporal disc margin with hyporeflective cavity extending into the optic nerve head was noted, and there was a clear communication pathway between the optic disc pit and the subretinal or intraretinal fluid collections. So these findings definitely confirm the diagnosis of optic disc pit maculopathy, explaining the atypical presentation initially thought to be central serous chorioretinopathy. So the takeaway points from my case is that not all serous detachments are CSCR, and after seeing the subretinal fluid, we should not straight away jump to the diagnosis of CSCR, and we should always evaluate the optic disc carefully in unexplained maculopathy, and OCT optic nerve head imaging confirms subtle pits missed on the clinical examination. Timely diagnosis of the optic disc pit maculopathy enables appropriate referral and optimal management strategies. Thank you.
Good afternoon everyone. Today I am going to present a free paper on correlation of OCT-based indices to predict the outcome of idiopathic full thickness macular hole following pars plana vitrectomy. Paused. Coming to introduction, idiopathic full thickness macular hole is one of the major causes of metamorphopsia and poor visual acuity in elderly. OCT established the role of anterior, posterior and tangential force in macular hole development. Various authors have studied the possible correlation between preoperative OCT findings and anatomical and visual outcome. The primary objective of my study is evaluation of preoperative OCT-based parameters and their association with postoperative anatomical outcome at 3 months. The secondary objective is their association with visual acuity at 3 months in logMAR. The study was conducted in AIIMS Rishikesh. It is an ambidextrous comparative study. The study period was from November 2019 to January 2025. The anatomical outcome was divided into U, V, W and non-closure type of macular holes, in which U and V type of macular hole were considered favorable, whereas W and non-closure type was considered as unfavorable anatomical outcome. Visual outcome was measured as BCVA in logMAR at 3 months post-operatively. These are the images. First image is showing U type closure of macular hole. Second is showing V type, the third is showing W type of macular hole closure, and the fourth is showing non-closure of macular hole. The patients with idiopathic full thickness macular hole who provided consent for PPV and had a minimum post-operative follow-up of 3 months and an OCT signal strength of more than equals to 7 were included in the study. The patients with secondary macular holes and coexisting vision-limiting ocular pathology, along with any previous intraocular surgery except uncomplicated cataract surgery, and who didn't have adequate medical records were excluded from the study. These were the following parameters that I measured in my study. On the right hand side, the parameters, on the left hand side, the indices which were derived using these parameters. So in the OCT SD line scan, in the first image we can see the B represents the base diameter, A represents the minimum diameter, E and F are nasal and temporal arm lengths, and C and D are nasal and temporal vertical heights. In the next image, we can see that OCT SD21 line scan, in which the area which is under blue outline represents the macular hole total area, under green outline it represents macular hole area, and under yellow outline it represents macular hole cystoid space area. These all parameters were measured using ImageJ software. Coming to the results, there were total 48 number of participants with a mean age of 62.7 years. The females were more than males with the average duration of symptoms of 4 months. 42% of the number of the patients underwent PPV alone, while 6 patients underwent PPV plus phaco. And there was significant change in visual acuity from pre-op to post-op, amounting to p-value of less than 0.001. 87.5% of the individuals had favorable anatomical outcome, whereas 12.5% of individuals had unfavorable anatomical outcome. Coming to the correlation of these parameters with post-operative outcome, in that we found that in case of anatomical outcome, only minimum diameter and macular hole height was correlated significantly with the post-operative anatomical outcome, such that the patients were having less minimum diameter were having good post-operative anatomical outcome, whereas patients having high macular height was having favorable anatomical outcome. Now coming to the post-operative visual acuity, in that we found that minimum diameter, base diameter and macular hole area were associated significantly with the favorable post-operative visual acuity, such that they are having positive correlation coefficient, which means that higher the value of these correlation coefficient, lesser will be the visual acuity. Now coming to the macular hole indices and their mean values and their association with the anatomical and visual outcome. In this we found out that MHI, THI and hole forming factor were associated significantly with the post-operative anatomical outcome, such that these all factors had higher values in the favorable anatomical group as compared to unfavorable anatomical group. Coming to the post-operative visual acuity, in that we found that MHI, THI, hole forming factor macular hole cystoid spare area index and macular area index were having significant correlation with postoperative visual acuity. In our study, the cutoff value of certain indices were different from what is established by previous studies. Like in our case, the mean hole index more than 0.35, the traction hole index more than 0.69, and hole forming factor more than 0.6 were associated with favorable anatomical outcome, which were lesser than which were previously established. So limitations of my study were that it is an ambispective study. Most of the phakic patients underwent PPV alone, and some had combined phaco-PPV, which could have influenced the post-operative visual outcome. Also, the macular hole of all size and varying duration were included, and predictors of outcome may differ across macular hole subgroup. But subgroup analysis was not feasible due to uneven and small sample size. The microstructural changes like ellipsoid zone, external limiting membrane integrity, which could impact the visual outcome, were not assessed. The strength of our study were the single surgeon performs all the procedures, there was uniformity in the surgical procedure, and it is a single study comparing both recent and previously defined macular hole parameters. In the end, I would like to say that the integration of both established and newer OCD-based parameters, especially those accounting for multi-directional traction, is a better guide for prognosis and surgical planning in idiopathic full-thickness macular hole. Also in our study, MHI was the single most significant factor for prediction of post-operative outcome. Further large-scale studies are needed to standardize the cutoff values and to validate the prognostic relevance for newer indices. Thank you.